Good evening, everyone, and welcome to the Children's Cardiomyopathy Foundation's Exploring Cardiac Imaging webinar. We are glad that you are joining us this evening. A few housekeeping notes before we begin. If at any point during the presentation you need technical assistance, please type your concern in the chat window. If you have any audio issues, you should be able to switch between your computer speakers and a phone if needed. Questions are encouraged and welcome during the presentation. Questions can be submitted via the question box in your control panel, and we will be taking questions at the end of the session, so please submit them as you think of them, and then we will be reviewing them at the end of the webinar. The webinar is being recorded and will be posted on our website, so you will be able to access the information again at a later date. Excuse me. And without further ado, it's my pleasure to introduce our presenters for this evening. We're thrilled to have Dr. Brian Feingold and Dr. Timothy Wong as our webinar presenters. Dr. Timothy Wong is an adult cardiologist with expertise in multimodality imaging. He helped to create and is currently directing the University of Pittsburgh Medical Center Hypertrophic Cardiomyopathy Center. He obtained his undergraduate degree in molecular biophysics and biochemistry from Yale University and trained at the New York University School of Medicine for medical school and internal medical medicine residency. He then completed his cardiovascular disease and advanced cardiac imaging fellowships at the University of Pittsburgh Medical Center. He is currently funded by a joint award from the American Heart Association and the Children's Cardiomyopathy Foundation to study the impact of myocardial fibrosis in those with HCM and participates in many other research collaborations. He is particularly excited to partner with Dr. Feingold on a collaboration focused on using imaging to characterize predictors of medium to long-term outcomes in adolescents following pediatric heart transplantation. Dr. Brian Feingold attended medical school at the University of Pittsburgh. He completed pediatric residency at the University of Massachusetts Medical School before returning to Pittsburgh to complete his pediatric cardiology fellowship and subspecialty in heart failure and transplantation at the Children's Hospital of Pittsburgh. Dr. Feingold is the medical director of the Heart Failure and Transplantation Program at the Children's Hospital of Pittsburgh, where his clinical care and research activities are focused on treating patients with all forms of cardiomyopathy and those who require and receive transplants. Dr. Feingold is currently funded by the NIH under a Clinical Research Scholarship Award and is the primary investigator on an American Heart Association grant for his work with Dr. Wong in assessing the impact of myocardial fibrosis on pediatric heart transplant outcomes. And with that, I will turn over the presentation to Dr. Feingold. Thanks so much for being with us tonight.
Thanks, Gina, and thank you everybody for joining. Let me make sure. So are you able to see the screen okay?
Not yet.
Not yet.
Oops. Okay.
Now?
Yes, we see the objectives.
Okay. And how about now, just to clarify?
Yep. Mm-hmm.
Okay. Fabulous. All right. So if something changes, please let me know.
Okay.
So again, thanks everybody for joining. I'll get started, and then Dr. Wong will sort of join in a little bit later. Some of the topics we want to cover tonight are really to review different ways of imaging the heart, and this will be a talk very much geared to the lay individuals and to parents and to families. Perhaps going over things you may see if you go to a cardiologist and your child has an echocardiogram. We also want to cover some of the benefits and limitations of some of the different imaging modalities that can be employed. And then later in the talk, we'll discuss the use of MRI to measure fibrosis, which is essentially collagen or connective tissue and scar tissue, and to measure that and some of the potential applications of this technology in pediatric cardiomyopathies. So let's start with the simple question of why do you want to image the heart? And some responses are that certainly you want to make a diagnosis if there's concern of a problem, by imaging the heart, you may get valuable information about what that problem is. And then if there is a problem or a concern for a problem, you can then use imaging serially over time to look for change. So, for instance, has heart function improved or worsened as time goes on? Are there changes in the thickness of the walls of the heart, which would be something that you may be interested in for hypertrophic cardiomyopathy, for example? Does valvular leakage develop within the heart, which can contribute to symptoms of heart failure? Or for just another example, could there be a clot in the heart, which sometimes may develop in forms of non-compaction cardiomyopathy or dilated cardiomyopathy where the flow is relatively stagnant? So I'll start with a case which is based on real-life events. So a previously healthy 14-year-old female complains of abdominal pain and nausea for about 4 days. Was seen at another hospital, and the evaluation there, the sum result of the evaluation there was concerning for a possible appendicitis. And so in the operating room, this child was found to have a normal appendix, which was a bit baffling. And when they looked back at the chest x-ray, they realized that the chest x-ray was not normal. So I'm going to show you normal here as well. And the obvious difference between the abnormal and the normal chest x-rays are the span of the heart shadow. This is the heart shadow here, this white density on the abnormal film, and this white density here on the normal film is the normal size of the heart shadow on a chest x-ray. And so these lines are actually equal size, and so you can see that there's a striking difference between the sizes of the heart shadows on these two films. And then, of course, the problem here is this is really as far as you can get with the chest x-ray. There's not a lot more you can say about why that heart shadow is enlarged. In medicine, we have a term called a differential diagnosis, and it essentially is thinking, well, what could be the problem? And in this case, with that x-ray, one possibility certainly would be a dilated cardiomyopathy. Another might be the long-standing, the consequences of long-standing severe leakage of the aortic valve, termed aortic insufficiency. And another possibility based on that chest x-ray would be what's called a pericardial effusion, or a fluid collection around the heart. And really it's impossible with that x-ray to tell exactly what's going on, and you may have multiple things going on and you really cannot tell just with the x-ray alone. So historically, medicine really had only x-rays for many years upon which to base diagnoses, and radiologists became very, very good at using x-ray to define structures, and when you see this overlay of normal anatomy onto an x-ray, you can kind of get a sense, in fact, that these structures are there, but when you don't have that overlay, for most of us, it's pretty hard to tell what's going on. So again, we come back to the question of why do you want to image the heart, and we need imaging modalities that are more, that provide more information than an x-ray alone. And so again, these qualifications are present, and then of course another useful feature of an imaging modality would be, can you use information from those images to perhaps predict events which might occur in the future? So one very common imaging modality that is used multiple times a day in our offices and in most pediatric cardiologist offices is what's called echocardiography, or echo for short. You'll hear people refer to it as I had my echo. And the principle upon which this works is similar to how a bat is able to use sonar to localize objects. I think this is just a simple schematic here showing a bat sending out a sound wave, and it hits an item. The sound hits an item, and there's a reflection back of that sound to the bat, which can then sense that, and it's much more adept at using sound than we are. And this same principle is how echocardiography, or echo, is used to image structures in the body. In this case, we'll be talking about the heart. So there's a probe which sends out ultrasonic sound, so we can't hear it, but it is a sound wave nonetheless. It bounces off the heart, and then there's a reflection of that sound wave back to the probe, which can interpret that reflection and then create a picture from that. The probe looks like this, and there's a crystal embedded at the tip of the probe here where electrical impulses go out and then sound off on the organ, or the heart in this case, and then there's a beam that returns, and of course then that is fed to a machine which can translate that signal into a picture. These are some pictures of echocardiograms, and they should be moving, so I hope that's the case. On the top panel, and these are normal, I'll go on to say that, these are normal views of the heart, what you can see here is the left ventricle and the right ventricle is here, separated by a wall between them, and there's a normal squeeze to the heart. Obviously there's valves that open and close, and again, the way echo works, and I'll show a slide momentarily, but you image the heart from different vantage points so that you can appreciate all of the structure. The heart is a three-dimensional structure, obviously, but echo is able to only create pictures in 2 dimensions, and so you have to take a series of these 2-dimensional pictures from different vantage points, which allow you to appreciate the 3-dimensional attributes of the heart. So what are the benefits of echo? Well, they're moving images of the heart in real time, so they allow you to appreciate the structure or the anatomy of the heart, and they allow you to appreciate the heart function. Clearly, there's much more detail or insight into the heart and heart function than is available on a chest X-ray. And again, as I said, the images are 2-dimensional, but you can form a 3D image, if you will, in your mind and with experience by moving the probe in different, with slight different tilts. And that's diagrammatically represented here. So again, there's a probe here and 3 different imaging planes. So if you start in the middle plane here and you tip the probe up, you would get to the first imaging plane, and if you tip the probe down, you'd get to the 3rd imaging plane. And each of these planes corresponds to different slices through the heart, which are shown here diagrammatically and shown here with their corresponding echo picture. So this affords instant information. It's safe as far as we know. There's obviously no radiation with an echocardiogram, unlike a chest X-ray or a CT scan, and there are no adverse consequences. And I don't mean to say that X-ray or CT scans should not be utilized. Certainly they have their role and their place in the management and care of patients, but they provide different information. We'll cover CT scans a little bit further on, but it is important to say that there is no radiation with an echo. There's no known adverse consequences to the bouncing of sound waves off of the tissues of the body, and so we feel very comfortable using this even in the youngest patients that we see. Echo is also generally very quickly able to be deployed, and it's mobile. Typically only requires 1 person to do the study, and that person can both perform the study and interpret it simultaneously. The machines are mobile and they can be brought to the patient. And these are some examples of echo machines which which are utilized, and you may have seen. The classic echo machines are large and provide very high-quality images, and generally as the machines get a bit smaller, the image quality isn't as good, but is still very good and sufficient. There's even echo machines that are now not machines, that are handheld portable devices, and you can imagine the utility of something like this for more remote locations that aren't as well staffed as the pediatric hospitals are in this country. And one has to wonder whether in the coming few years we'll have echo capabilities in the palm of our hand. So what I hope to show next, or will show next, are some echo appearances of the different forms of cardiomyopathies, most common different forms of cardiomyopathies which we see in the pediatric population. And what I'd like people to appreciate from these images are the fact that you can draw information about both structure of the heart and function of the heart. Excuse me. And in each, I've tried to incorporate a normal comparison echo so that you'll be able to appreciate these differences. So again, these should be moving pictures, so if they're not, please let me know. But these are images of dilated cardiomyopathy on echo, and that's shown in the image with the abnormal label on it. And onto the other side is the normal echocardiogram, and this is a view that's called the four-chamber view. So you can see in the normal the left ventricle, the right ventricle, the right atrium, and the left atrium, and this is the mitral valve. You see these same structures in the abnormal echocardiogram image, but clearly the differences are that the left ventricle is markedly dilated and rounded, as opposed to being a bit more elliptical and like a football. And it doesn't squeeze well. And in fact, as this wall, the lateral wall, contracts, the wall between the right and left ventricles, we call the septum, moves the other way. And that's not the case here. As you see, as the heart squeezes in this image, both walls move in together, and that's the normal efficient squeeze of the left ventricle. This is another complementary view of dilated cardiomyopathy on echocardiogram. And again, in the normal, you see here the left ventricle and the septum, the wall between the two ventricle chambers, the right and left ventricle. The mitral valve is here in this view. And again, a similar appearance here, but what you see is a dilated left ventricle compared to this side. A poorly contractile septum that in fact moves the other way, we say paradoxically. And this is quite abnormal. So moving on, this is an appearance of hypertrophic cardiomyopathy on echocardiogram. And again, we have our reference normal image here. And the striking feature, these should also be moving. I apologize if they're not, please let me know. The striking feature here is that the septum is quite large, much larger than on the normal echo, and is, we say, echo bright, is a bit brighter than the wall here. And you can in fact see that the wall it's a little bit harder to appreciate, and I don't know how great the image quality is, but the wall is not just this part here, but you see movement within the chamber, and the chamber almost obliterates itself. The muscle is so thick in this condition that it leaves very little space for the blood to fill the chamber to then be pumped effectively out of the heart. So we'll move to a different vantage point again for hypertrophic cardiomyopathy with normal here and abnormal here. Again, these are moving pictures. And what you see here again is this markedly enlarged interventricular septum, and it's obviously, I'd say 4 or 5 times the width of the septum in the normal image here, and you can see how it crowds out the space within the left ventricle so that there's much less room for the blood to be able to fill the chamber and then to be able to escape the chamber with each beat. Moving on, this is restrictive cardiomyopathy, which is a different form of cardiomyopathy where the ventricles actually squeeze normally, but they don't relax normally. And the result, the long-standing result of impaired relaxation of the ventricles are that the upper chambers, the atria, the right and the left atria, dilate massively. And so this is a classic appearance of restrictive cardiomyopathy on echocardiogram, where you see normal atria size here on the normal moving echo, and here you see a very large right atrium that that actually leaves the imaging field here, a large left atrium with normal function, that normal squeeze, and what appears to be subjectively normal function. Also moving to non-compaction cardiomyopathy. So in these images here that should be moving, we see again a normal appearing left ventricle here. And non-compaction cardiomyopathy, also called left ventricular non-compaction or LVNC, the striking feature is that this left ventricle is very heavily trabeculated, meaning it's instead of being a smooth, relatively smooth-walled inner surface here in the chamber, you see these ruts of muscle that jut out into the chamber. And in fact, these are sort of peaks of muscle with valleys in between. We also see that the left ventricle is quite dilated relative to the normal left ventricle and does not squeeze as well. And non-compaction has a number of different, we say, phenotypes or appearances, and some can be somewhat hypertrophic or thickened, and some can be not quite as hypertrophic and thickened, and this is a bit more on the thickened side. And again, for non-compaction cardiomyopathy, we see in a complementary view here, and just another sense of the left ventricle being both dilated, certainly poorly contractile relative to the left ventricle here, and this trabeculated appearance to the, we say, the apical surface or the point of the heart. So that concludes that part of the talk. We're going to talk a little bit about some of the other things that are seen on echo and then move forward from there. I've had families ask before, well, what are the blue and the red colors or orange colors that we see on echo, and what does that tell you? Well, what we were looking at before really had no color. Those were, we say, two-dimensional echo images, and they're very useful for assessment of structure and of function to an extent. And then there is Doppler imaging, which is used to interrogate either the movement of blood or movement of the tissue itself of the heart, the walls of the heart, if you will. And this provides added information about how the heart is working. So here, this now should be a moving clip, and you see both orange flow this way and some blue with yellow and maybe a little, mostly yellow flow going the other way. And by convention, the probe, or the tip of the probe that is on the patient's skin is at this point here. And so flow towards the probe is orange, flow away from the probe is blue. And you can see here that there's flow towards and away across this valve here. And this, if we were able to slow this down, which unfortunately I cannot with this presentation, you could see that this blue flow is actually flow as the heart is squeezing, and so it's regurgitant flow moving in the opposite direction back from the ventricle to the atrium, which is the abnormal direction of flow. And so not only can we visualize that process, but you can actually then use the echo machine to put essentially an electronic probe across that region, and these are now successive heartbeats that have occurred over time, and you can actually see how the velocity at this along this line changes with time. So with each beat, the velocity speeds up and then slows down and then speeds up and slows down, and this slows down, and this corresponds to that blue jet that you're seeing here. And so you can use this peak velocity to estimate, in fact, the pressure in this chamber, which is a very helpful number that we will sometimes use. So this is just an example of how by assessing the movement of blood or the tissue and assessing the directionality and the speed, you can actually gain additional information about heart function. So echo, obviously what we want to do is to quantify what we're seeing on echo. It's very nice to be able to lay eyes on something and say, oh, this is a problem and this chamber is dilated, or this chamber doesn't squeeze very well, or this chamber looks thickened. But to compare over time, because of inherent differences between observers and across patients, what you'd love to do is have a set of standards that you can compare and say is something normal or abnormal. So certainly on the two-dimensional images, you can imagine being able to measure, for instance, in that hypertrophic cardiomyopathy echo, the width of the septum and exactly how big it is, and have an exact measurement for that, and say how much larger is that septum than normal. Another assessment of heart function that echo allows is an assessment of the ventricular function of the squeezing chambers, the bottom chambers of the heart. The two most common ways to assess that are something called ejection fraction and shortening fraction. And these are probably terms that patients have heard, or parents of patients have heard as they've gone to see their child's physicians. And then and I'll cover those in the coming slides just for general interest sake and how they're quantified. And then there are other ways to assess heart function. And one is something called a myocardial performance index, or the TI index, and this is a combined assessment of both the squeeze function of the heart and the relaxation function of the heart. It's not always intuitive, but not only does the heart is not only dependent on how well it can squeeze, but if it never relaxes after each squeeze, then you can't refill the chamber with blood to get blood out on the next squeeze. So the heart is actually dependent on both its ability to contract or squeeze and relax, and do that in an appropriate fashion in order to be able to provide blood flow to the body. And then there are other measures that you can that give you a sense of how the heart relaxes, and something called tissue Doppler, which I'm not going to touch on because it's more of an advanced subject, but allows us again to get assessments of how the heart relaxes. So this is a two-dimensional image of left ventricles contracting and relaxing at the level of the papillary muscles. And the shortening fraction is determined essentially by dropping a line down through the left ventricle, electronically of course, as it's moving. And this is that line here. And again, this is time moving this way, and so these are successive beats. And what you can see is this is sort of an ice pick view of what this line is seeing graphed over time. And so this region here corresponds to this here. The empty space here of the chamber corresponds to this area here. And down below the posterior wall of the left ventricle, in between these dots, corresponds to this segment of the image here. And so you can actually measure both the diameter of the ventricle in the relaxation phase, end diastole, and at its height of squeeze, if you will, in end systole. And by taking the end diastolic dimension, subtracting the end systolic dimension, and dividing that whole thing by the end diastolic dimension, you come up with the shortening fraction. And so 42% is a perfectly normal shortening fraction. That's how that number is obtained. Ejection fraction is a similar concept, but instead of a two-dimensional assessment, the echo machine is able to attempt to estimate the volume of the left ventricle, both in end diastole, as it's maximally relaxed just before squeezing, and in end systole, just as it's finished its squeeze just before relaxing. And by quantifying that volume with some fancy math, you can get a measure of the ejection fraction. So they're similar. They're not exactly the same. They're on different scales, but they both tell you about the squeeze of the left ventricle, and these are very common measures that you'll hear in cardiologists' offices everywhere. Just a very quick word on the tissue Doppler and speckle tracking. So these are more advanced measures of heart function, and they are not truly experimental. They're being employed in a clinical practice, but they're much less commonly used, I would say, and hopefully in time these will be able to provide us additional prognostic information, so the ability to visualize function that is not inherently obvious by watching the echo image move, but to be able to discern features of how the heart moves using the advantages of the computer algorithms to assess the strain of the ventricle. And there are two different methodologies to do this. One is called tissue Doppler, and one is called speckle tracking. And I'll leave it at that, but to say that echo is still evolving and advancing, and hopefully we will have additional assessments of heart function, and hopefully some of these will be prognostic and allow us to tell who may get sicker as time goes on and who may respond to medical therapy. A few other points about echocardiogram. Most of the studies that are done in children are done as transthoracic studies, or TTE, and these are through the chest wall where the probe is placed directly on the wall and the images are created through the skin and through the surrounding tissue and potentially the lung. Sometimes if there's too much lung tissue or there's too much body tissue between the heart and where you're able to image from outside the body up against the skin, patients will have what is called a transesophageal echo, or a TEE. And these are commonly done, as I said, in the setting of if there's poor image quality and you can't see with enough resolution what it is you'd like to see, or they may be done intraoperatively if somebody's having heart surgery. And in this case, the probe is a little bit more, is a longer tube with the probe at the end that does the same thing as it would from outside the body, but does it from the esophagus, or the swallowing tube, which sits just behind the heart. And so you can generate pictures here free of a lot of the interference that may occur as you get older and bigger. And these are just some examples of echo probes here. A few other quick notes about imaging. So cardiac catheterization is, in the current era, not terribly helpful from an imaging perspective for cardiomyopathy. We can get most of the data we need from echo, and then from combining that with either CT scans or MRI scans. Catheterization is most useful in the care of a cardiomyopathy patient when you really need to know information about the heart, the physiology or the hemodynamics, what the pressures are inside the heart. And this is often done as part of a heart transplant evaluation. It can be useful to help guide the management of patients with restrictive cardiomyopathy, and sometimes may be useful in the management of patients with hypertrophic and dilated cardiomyopathies. As I said, the pictures that what we term angiography, where we shoot dye into tubes, into catheters that are inside the body and inside the heart, are not typically part of the routine way to image or manage cardiomyopathies. And cath tends to be most helpful in the pediatric realm for the management of patients with congenital heart disease. Very briefly on cardiac CT, or otherwise commonly referred to as CAT scans. These are very good for structure and anatomical assessment, and allows you not only to see the heart, but to see the heart in the context of the chest and other features outside the heart. They are capable of providing functional assessments of the heart, and this is an example of such an assessment here, reporting out an ejection fraction. However, most of the time in pediatrics, it's not necessary to do CAT scans or CT scans for functional assessments. These are just some examples of imaging that can be obtained by a CT scan, and so here is a heart in the chest, and you can see, for instance, a small pulmonary vein, which is a structure not typically well visualized by echocardiography, that can be very well visualized here, and there's a narrowing here as that vein is returning to the back of the heart. Here, a structure such as the right pulmonary artery, one of the arteries going off the heart, giving supply of blood to the right lung, can be measured rather precisely in two different dimensions here. And this is just an example showing that you can get very nice pictures of very tiny structures. So this is the aortic root, the main blood vessel off the heart. And these are coronary arteries, so the arteries that are the first branches off the aorta that go back to the heart and give the heart its blood supply. And so you can see very nicely here the origin, the abnormal origin in this case of this coronary artery. And this is the type of utility of a CT for the most part, in my impression in pediatric imaging. So the downsides, if you will, of CT scan are that they use radiation. It requires the patient to go to the scanner, to go to the machine. So whereas echo, generally the machine can be brought to the patient. That's different for a CT. And in my mind, it's not really clear that it's any better than echo or MRI, which Dr. Wong will talk to us about shortly, in terms of functional assessment of the heart. So I think it's not really practical for the routine imaging or assessment in pediatric cardiomyopathies for the reasons that we said. It's usually not as quick to interpret as echo, and there's the radiation exposure, which doesn't exist with either MRI or echocardiography. So with that, I'm going to hand it off to Dr. Wong, who will tell you a bit about some other imaging modalities, and then we'll take it from there. Okay, so Tim. Okay, Tim, you should be good.
All right. All right, Brian, can you see my slide for overview?
Yes, I can.
All right. Thanks so much for the segue. So I'm going to continue where Dr. Feingold left off and cover a couple of other imaging modalities, but spend a lot of time on cardiac MRI because this seems to be a very versatile imaging modality that can really answer a host of questions regarding diagnosis and prognosis for cardiomyopathy, both in the adult population and more recently in the pediatric population. And then sprinkled throughout, we'll go over a few sample cases of how imaging can impact patient care, and then I'll turn it back to Dr. Feingold to share another case or two more, just to provide the most comprehensive overview. So moving forward, I like to describe cardiac MRI to my patients as kind of like a big machine that's the end result of when you take a big magnet and a radio and smush them together. And we take advantage of the fact that in the presence of a strong magnetic field, when you use a radio wave to perturb protons that lie in different tissues, the protons will then absorb and release radio frequency energy as well also. And the key here is that protons in different tissues will generate different signal, and that's how we can tell different tissues apart. And this is what we call contrast. So on the top left, you can, or on the top right screen, you can see a moving image of a cardiac MRI. I apologize for the a blank screen at the end of the clip. But this is done without contrast. So even though the blood pool looks white and the muscle looks dark, we're observing this contrast, just because of the inherent differences of how protons behave in blood and the heart muscle. And this is a case of a patient with hypertrophic cardiomyopathy. So the top chamber of the heart is the right ventricle. The bottom chamber of the heart is the left ventricle, right atrium and left atrium here. And Dr. Feingold had showed a case before where the septum was extraordinarily thick, and this is a very similar case, but just of MRI. So the bottom line is, without any intravenous injection, because MRI can elicit different signal from different tissues, we can actually tell them apart and get a lot of useful information similar to echo, such as the left ventricular function, the ejection fraction, how the valves are working, the chamber sizes, and things like that, all of which are important for both diagnosis and prognosis in all types of cardiomyopathy. I'm going to shift the discussion a little bit and talk about how we can use intravenous contrast, IV contrast, which in the MRI world is typically a type of gadolinium contrast, which we can use for two things. One is we can track abnormalities in the muscle itself or highlight where the blood is actually flowing. So I'm going to first talk a little bit about
Dr. Wong, we lost your audio.
20 minutes later after we took the first image, after we've added gadolinium contrast. So you can see here that the very thickened muscle, the interventricular septum, is no longer as homogeneous. And I don't know if everyone can see my arrow, but in the septum itself, you can see areas of lighter and darker signal. The darker regions are what we call, more normal appearing, whereas the white regions are areas of scar tissue, and to use the medical term, it would be termed myocardial fibrosis. So this is one of the major uses of cardiac MRI and contrast, in that we know now that the more fibrosis or scar tissue you have inside the heart muscle, no matter whether you have a hypertrophic cardiomyopathy or a restrictive cardiomyopathy, the more fibrosis you have, the more deleterious the effects are on the heart, and on average, the worse the outcome. And this is important for physicians to establish, because for those who have a worse prognosis, it may identify the patient to receive more aggressive follow-up and or therapy depending on the specific type of disease. The other application of contrast, which I'll highlight just briefly, but this is typically more used in the congenital heart disease arena, is to do MR angiography, which is basically using contrast to very clearly show where the blood pool is and is not. And the case in the bottom middle of the screen here is a case of coarctation of the aorta, where in the loop of the aorta here you can see this dark spot, which represents a stricture or a very tight narrowing of the aorta, as the blood comes out of the heart, and this can lead to problems affecting the heart muscle and also blood flow downstream of the narrowing as well also. So I kind of talked a little bit about the big picture of MRI. I promise this is the only sort of math type of screen here, but this is a large part of what we do, and I just want to use this slide mainly as a way to introduce a couple terms that you may hear in the office. And the main terms that we'd like to talk about are T1 and T2. And I had mentioned previously that MR takes advantage of different ways protons send signals back at our detection coils, and that depending on where the proton is, whether it's in one type of tissue or a different type of tissue, the signals that they send back are different. And the main classes of signals that we care about are what we call T1 and T2 relaxation times. And all these times refer to is basically the way the signal changes over time, and they're typically exponential relationships. So overall, if we do math, knowing how much energy we deliver and at what time, we can then expect different tissues to send back signals that change over time. And by setting where we measure the imaging, we can then determine why one tissue will have a brighter signal, based on a higher position on this curve, compared to another tissue which might have a lower signal. So overall, MR is you can basically boil it down to T1 and T2 and what tissues have high T1, what tissues have high T2, and what tissues might have, a little bit of both. So I'm going to change the discussion a little bit now and then talk about, why use cardiac MRI. I think traditionally it's been labeled as a imaging modality that's, a little bit cumbersome because of the large room and buildings needed to support such equipment, as well as also an expensive modality. But from the physician standpoint, there are definitely certain unique strengths that I'd like to highlight that I think is responsible for why we're using more and more MR these days. The first strength is that MR has a very high resolution. And I've taken one of my patients who has undergone both an echo, an MR, and also a nuclear scan, just to show the differences in the image quality. In the echo, this is the left ventricle here. And in the MR, in the middle of the left ventricle is in the kind of like the middle to right-hand corner. And then in the right-hand image, the nuclear image, the left ventricle is the bright kind of upside-down U represented. That represents nuclear cardiac imaging. And you can just see, at face value, that MR probably shows the most detail and it has the crispest image. Another strength of MRI is that it does not need to use ionizing radiation like the CT modality that Dr. Feingold talked about, as well as the nuclear cardiology imaging. Another strength is that it can do a whole host of heart characterization. It can do cardiac function and dimensions like echo, but because it's often not limited by echo imaging windows, we can get very good quality images, even if the echo images are a little bit more blurry. We can get information about the state of the muscle itself, how much fibrosis or scar tissue is inside the left ventricle. We can use MRI for stress testing. We can use it to quantify how much, how valves are functioning, how much blood they're leaking or not leaking. And then we can also use it to characterize, the presence of any masses inside the heart, whether there might be a tumor growing inside the heart or whether it's a blood clot inside the heart. And just to play devil's advocate a little bit, there are some limitations to MRI as well also, and some of these include the fact that it takes more time than some of the other modalities. I'd say an average MRI takes about an hour of scan time, and that because most patients are scanned inside the bore, there's problems with claustrophobia, that sedation may or may not completely eliminate the fear of being inside an enclosed tube. The presence of certain types of metals, especially those that are magnetic, is also a reason not to get an MRI. And then finally, for those scans that are eligible to receive contrast to help improve the information that we can obtain from the images, if the kidney function is not good, then that's another reason not to do, not to administer contrast. And then finally, for certain things, especially to determine how tight a valve is, not how leaky, but how tight a valve might be, we still typically use echocardiography more so than MRI for several technical reasons. So hopefully this gives all of us just a good overview of when to and when not to use MRI. And then now to steer the discussion over to how MRI can impact patient care, I'm going to take the example of hypertrophic cardiomyopathy. And just kind of go over a few points as to how specifically cardiac MRI can help in management. And the first point is that there are many other conditions that can look just like hypertrophic cardiomyopathy on echo and on EKG, and which can have some overlap in symptoms as well also. And then cardiac MRI, especially with the use of contrast, can often help us in determining, is this a familial type of hypertrophic cardiomyopathy, or is it what we call a phenocopy, another condition that just looks very much like HCM, but is actually caused by different mutations or other systemic conditions. And MRI is very good at identifying alternate clues to suggest these differing etiologies. Once we've made the correct diagnosis, MRI can also be very helpful in managing symptoms. And because of its high resolution, we can get precise quantification of how thick the heart muscle is, where the mitral valve is located, and how it might be or might not be getting in the way of the blood flow. And especially if there's consideration for surgery to fix some of these structural problems, MRI can give very high-resolution, three-dimensional information for the cardiologists and the surgeons to plan surgical intervention or other therapies. And then the final point I'd like to just hit home again is to talk about prognosis. Basically, what are the chances of something bad happening from the heart standpoint over the next few years? And we now have data, and I've copied one of the main papers describing this, that shows that quantifying how much scar tissue there is inside the heart has been determined to be an independent risk factor for bad outcomes, including ventricular tachyarrhythmias like ventricular tachycardia, heart failure, and even sudden cardiac death. And so, at least in most, I think, high-volume HCM centers, cardiac MRI is now part and parcel of the routine initial evaluation, just to provide a lot of this information. So I'm going to get a little more specific now and bring up a couple cases where imaging really helped play a role in either diagnosing or helping physicians manage a particular patient. So these are still frames here. So if it's not moving, that's intentional. This is a case that happened to an adult, but we could see it happening in the pediatric population as well also. And basically, this was a patient who came in with some chills and sweats, with a sensation of his heart pounding, and was diagnosed to have ventricular tachycardia in the emergency room. And the emergency room physicians treated the tachycardia and admitted him for further evaluation as to what may be causing this. And initially, the echo showed a very thickened interventricular septum. In the arrow here on the top left panel, you can see that the septum is about 2 centimeters thick. And you see about the same findings in the top right panel. This is just a 4-chamber view of the heart as compared to the peristernal long axis view. And then, so the initial suspicion was, maybe this person has hypertrophic cardiomyopathy. He had no high blood pressure, and the heart looked, thickened in a pattern similar to HCM. And for completeness sake, we decided to do an MRI just to further characterize the heart muscle to look for any scar tissue and things like that. And then on the non-contrast image, we found results similar to the echo, which showed a very thick interventricular septum, about 2 centimeters thick. But surprisingly, when we gave contrast and waited a few minutes for the contrast to percolate through the heart, in the area that's highlighted at the base of the interventricular septum, we see an area of essentially blackness that suggests that no contrast is penetrating that area at all. And what this suggests is that this is not hypertrophic cardiomyopathy, and after some additional testing, including blood cultures that found a high load of bacteria inside this patient's bloodstream, this turned out to be a myocardial abscess, which is medicalese for like a pocket of infection. We're not sure how the person got the bacteria in his bloodstream, but we were able to detect many from many samples that he had a high burden of a bacteria called Listeria, and that was most likely had settled in his heart and causing a pocket of infection that, to traditional imaging looked just like hypertrophic cardiomyopathy. The happy story is that this person was appropriately treated with antibiotics and was able to be released from the hospital after several more days. This is a second case that I just wanted to bring up, and I apologize for the black frame at the end of the clip. This was a case of a 18-year-old woman who was a cheerleader and needed a routine sports physical evaluation. The interesting part was that her mother had a history of hypertrophic cardiomyopathy, and one of the doctors heard a slight heart murmur during the initial sports physical. This led to an echocardiogram, and you can see here that the base of the interventricular septum here is just a little bit thick. By adult standards, it was borderline thick, maybe around 1.2 or 1.3 centimeters thick, and the remaining sectors of the heart were appropriately thin, or normal thickness as well also. So now the question was, what do we do with this patient? Because the guidelines suggest that for those with hypertrophic cardiomyopathy, that there should be some exercise restriction from a safety standpoint. So what we did next was that we did a MRI to try to get more information. And what we can see here is that the MRI again showed that there was a region of mild thickening here. Again, not too impressive by adult standards, but at the same time it did look somewhat out of proportion to the rest of our heart. And what really helped us in this case is that after giving the patient contrast during the scan, we were then able to see some fibrosis occurring inside the most thickened region of the heart muscle, which is most consistent with a diagnosis of hypertrophic cardiomyopathy. And because this was a fairly tough decision to make whether or not to place a activity restriction on someone who had been cheerleading essentially her whole life, the MRI gave us much more confidence in providing the family and the patient with the best diagnosis possible. We later on did some genetic testing in the family and were able to find a routine or a known mutation in the troponin gene that has been previously described as causing hypertrophic cardiomyopathy. So in this case, the imaging all fit, and we were able to get a good diagnosis even before the 8 to 10 weeks it took to actually get the genetic tests back. I'd like to spend a few minutes moving on beyond these couple patients and then talk about some of the cutting-edge techniques within cardiac MRI research. And a lot of interest lately has focused on how to better detect this fibrosis or scar tissue that we can find inside the heart. So just to throw a few terms out there, the traditional way of detecting scar tissue, which I've shown up to now, is what we call late gadolinium enhancement. And this is a technique where we give intravenous gadolinium into the patient, and after 10 minutes, we then take more pictures focusing on the heart muscle. And this technique can detect macroscopic or visually detectable areas of replacement fibrosis. And one of the limitations of this technique is that we rely on differences or relative imaging in terms of some areas of the heart have to be abnormal so that we can then compare it to normal areas of the heart. So if there's a clump of fibrosis somewhere inside an otherwise normal heart, this is a very good technique to find that type of abnormality. And this is clinically available. Any MRI scanner that does cardiac can look for this. And it's I'd shown the paper by Dr. Marin and his group previously that showed the prognostic significance of identifying macroscopic fibrosis inside the heart muscle, and it's definitely been integrated into routine clinical use for prognosis. However, we know that not all scar tissue deposits inside the heart in such a manner, and that sometimes you can get a more hazy or diffuse deposition of scar tissue that may not be as localized and focal as that which can be detected by the late gadolinium enhancement technique. And we now have techniques called T1 mapping, where instead of relative T1 signal, we can detect absolute T1 signal. So that means even if there's no visible fibrosis that we can see, we can still detect if there's a little bit of fibrosis sprinkled throughout the heart muscle that we can now detect because we can measure the absolute T1 signal intensity. This is a new technique, so of course we've had to validate it against gold standard techniques such as looking at heart tissue under a microscope and comparing it to what we see on MRI. There are certain other conditions that can elevate some of these findings that we can see independent of scar. Amyloid is a protein deposition inside the heart, and the edema is basically a swollen heart muscle due to acute inflammation. Because this is a new technique, it's only available at certain expert centers that have kind of pioneered the use of this, although I can tell you that every cardiac MRI manufacturer plans to incorporate this into clinical pulse sequences and clinical use probably over the next several years. So I'd like to just show some pictures of what this new technique looks like, partly because this is a hot area of research into cardiomyopathy, and also because Dr. Feingold and I happen to be collaborating on this, and we're very excited to look at how this might help us better predict outcomes in pediatric transplant patients. So I'm going to highlight several images where we do this novel technique called T1 mapping before we give any contrast. And then after we give contrast, we still do the traditional imaging called late gadolinium enhancement. And you can see that there's a very small area where the red arrow is of fibrosis that we can detect on this. But if we do post-contrast T1 mapping and then merge the pre and post-contrast maps together, we can get what we call an ECV map. This is a diffuse myocardial fibrosis map, and what this shows is that this entire heart is actually severely diseased. So even though the late gadolinium enhancement image on the left here showed a spot of fibrosis that we could see with the naked eye, this diffuse fibrosis measurement technique actually points out that the entire heart is significantly abnormal, most likely due to the deposition of diffuse fibrosis. And the bottom slides I'm not going to spend too much time on, but they're just different ways of quantifying late gadolinium enhancement, just to show that even if we teach the computer how to quantify it, it still is going to miss the majority of the scar burden in this patient. So with that kind of very brief overview of both MRI and some of the newer technology MRI, I'm just going to finish up my time with a couple of slides on just some of the other imaging modalities that I think are used, but probably less often among pediatric cardiomyopathy patients. One technique I'd like to touch upon is nuclear cardiology, and this is a technique where we use a radioisotope tracer that's injected intravenously into a patient, and that is absorbed by the heart muscle. And once it's absorbed, we can then trace it by using a gamma camera, which detects gamma rays emitted by the radioactive tracer, and then we can determine ejection fraction, how the heart is beating. We can determine blood flow to the heart muscle, and the slides down here show a normal heart underneath at rest. You can see that there's a nice donut here, but on the top slides it's the same heart, but after a stress test has been done, you can see that the top half of the donut has fewer counts compared to the bottom half, and this is suggestive that there may be an obstruction in a blood vessel in the left anterior descending artery that's not permitting enough blood flow to get to the top chamber of the heart. just for orientation's sake, this heart looks like a donut because we're cutting the left ventricle, kind of like a bread loaf. And then this is the blood cavity inside the left ventricle, and this is the kind of like a side or like an axial view of the left ventricle here. Some other tracers, instead of measuring blood flow, can also measure the metabolism of the heart muscle. So if we give a tracer that mimics a sugar molecule, we can then measure how metabolically active parts of the heart are or are not. In general, these techniques are used less often in cardiomyopathy, mainly because it's typically the congenital heart disease patient that will often have anomalies in the blood vessels and things like that to cause abnormal amounts of decreased amounts of blood to get to the heart and things like that. But in selected cases, it can still be done. The final thing I'll touch upon is just myocardial stress testing in general. And this is a large topic that we could probably spend the whole hour on, but just to touch upon it briefly, the main purpose of this type of stress testing is to see how the heart responds to exercise or medication in terms of the heart rhythm or the blood flow to the muscle, and also the blood pressure response to the stress. And the exercise stress can typically be accomplished either through a treadmill or a bicycle. If the patient can't exercise, we can use a pharmacologic stress test for, instead of the treadmill here, we would have the patient lying on a stretcher and then administer a stress medication agent that mimics the flow of blood during exercise, so that we can then infer how the heart would respond to exercise. During the entire test, we monitor the EKG, the electrocardiogram, the electrical rhythm of the heart, as well as the blood pressure. And this can give us useful information as to whether any abnormal heart rhythms are triggered by exercise, and also how the blood pressure responds to exercise. And then finally, in selected patients, especially those with certain types of cardiomyopathy, we can use this type of treadmill test, but put a very form-fitting face mask on, so that we can measure what's called the MVO2, or the myocardial oxygen consumption, which can also give us an idea of whether a functional limitation is due to the patient or due to the inability of the heart to provide enough blood and oxygen for normal function. Again, stress testing isn't always used, but especially in cardiomyopathy patients, sometimes a stress test with an MVO2 test can be used to quantify how sick the heart is from a functional standpoint. So with that, I'm going to turn it back to Dr. Feingold for just one or two more cases, and then I think we'll be taking questions after that.
Thanks, Tim. So, Gina, I'm going to actually ask at this point, I think we can also just wrap up if that's appropriate, given that it's already a little bit after 7. What is your preference?
It's totally fine. With what we can do with respect to the questions is that anyone that submitted a question, Dr. Feingold and Dr. Wong have graciously agreed to respond to any questions that we don't have time to get to via email. So what I can do is, after the presentation, I will send the presenters a list of all of the questions that were asked during the presentation. There's a handful of them. And so then I can send that back out to the group once we get the responses. But yeah, since we are a little bit over time, we can definitely take care of the questions offline, and then I'll leave it up to you, Dr. Feingold, however you want to leave it with where you are in the presentation.
Yeah, I think really what I had to present was sort of bells and whistles, in that I've gotten the point across that I wanted to with respect to imaging, and so I think probably just in the interest of time, having run just a little bit late, I think we should probably wrap up, if that's okay.
Okay, yeah, that's totally fine. Thank you both so much for sharing your time and your expertise with the group tonight. We appreciate it so much, and it was extremely helpful and very informative. And to all of our audience, we thank you for taking the time to participate in tonight's webinar. At the close of the webinar, you'll see a screen automatically pop up with just some feedback that you can share about future programming for webinars and different topics that you might be interested in seeing that for us to offer. And as I mentioned, we'll get the questions sent out, and we'll follow up with you on that. And we'll also send out the link to the recording so that you can go back and view it at a later date as well for any additional information that you may want to review. And again, thank you both, Dr. Wong and Dr. Feingold. We really appreciate it.
Thank you very much. We appreciate the opportunity.
Thank you. Yeah, my pleasure.
Have a great night, everybody. Take care. Bye-bye.